think that ipilimumab will have its time and then be surpassed by PD-1 blockade? So Reinhard, I mean, what can you tell us about upcoming trials whose data I assume will be available in the next year to 2 years?
So we are impressed today by the EPI data, but we all are aware that anti-PD-1 therapy has such a beneficial AE, adverse event profile. So therefore, anti-PD-1 is more or less the favorite drug in the adjuvant setting. There is far less toxicity, and from the stage 4 data we know, and this has shown in several prospective randomized trials, anti-PD-1 has a better efficacy. So to investigate this in the adjuvant setting is essential, and I think this has already been done now. So we have the comparison IPI 10 milligram versus anti-PD-1, and we have the EOTC study comparing a placebo to anti-PD-1 therapy. Unfortunately, it will take another 4 to 5 years until we know whether anti-PD-1 will be really as effective.
In terms of overall survival.
Of overall survival. And we still have to keep in mind that the anti-PD-1 mode of action depends on the presence of tumor cells. And in a disease where you have a minimal residual disease, there might be some drawbacks and feedback mechanisms that reduce the efficacy.
Although, is that urban legend or is that reality? Axel, do you really buy into that idea that you need a tumor microenvironment for PD-1 blockade to work?
From the theoretical standpoint, Reinhard is absolutely correct. But on the other hand, you know, it's an activation of T cells which is independent from any PD ligand 1 expression on tumor cells, which we know from stage 4 melanoma. And therefore, I'm very hopeful, and I think we are speaking about the same expectations, that PD-1 antibodies will soon replace ipilimumab simply because they are more efficacious and less toxic in stage 4. And I strongly believe the same will be seen in stage 3. And also I want to point out that there might be an alternative for IPI. You know, IPI 10 versus 3 was tested in the US compared to high-dose interferon. So I believe it's a very important trial, the intergroup study, because it's not only the dose of 10 which is tested again, but it's also the testing for only 1 year compared to IPI of 3 mg per kg for 1 year, and high-dose interferon as approved. So it's not telling us if this is superior to just a placebo, it's telling us if this is superior to so-called standard of care in US and Europe.
Yeah, but won't that take a long time to become mature? You have 2 active regimens, IPI 3, IPI 10, that could take a long time.
Plus now it's much more difficult to analyze because we have drugs that are impacting overall survival afterwards when patients relapse. So it will be now the trials that are running now, because the patient, when they relapse, they will have a treatment that has some efficacy, which was not the case before. So we have to be ready to change our way to analyze the results.
But I don't think that overall survival is the endpoint of the future, because we have so many active drugs for stage 4 disease. And most of the trials, with only one exception, have chosen, you know, relapse-free survival as the endpoint. And this is not impacted by subsequent treatment modalities. And therefore, you know, in terms of RFS, which is charming because we can see the results earlier, you know, I think that we will have clear results.
So it sounds like, to sort of close out the book on the adjuvant discussion, it sounds like RFS will be the endpoint of the future, not OS, which I think we all agree with. So, Dirk.